Good afternoon, everyone. My name is David Lindeman. I'm Director for CITRIS Health here at CITRIS and the Bonato Institute. Delighted to have you with us today for our CITRIS Research Exchange, and welcome again to the 12th year of our Research Exchange program. As you know, we've had a lineup of outstanding presenters over the years, and this year is no different. Just unfortunately, instead of being at Sudarjadai Hall, we're all joining virtually, of course. For the fall series, as you can see, we will have still several more excellent presentations coming up in the coming weeks, and we look forward to having you join us for that. Particularly next week will be an additional CITRIS Health related program, and it will be a presentation by Rachel Cooperman of Eyes Lab, who has been developing a new startup company, medical management in epilepsy, and the title is Journey into the Unknown. Rachel has actually been building her company through work here at our CITRIS Foundry. So we're delighted to have her present her updated programs, and you can again look forward to registering that at our webpage. Based on the issues around COVID-19 and the pandemic, CITRIS has recently been focusing a great deal of its efforts not only on our new innovation programs, but on particularly programs related to telehealth and the way we're making changes in healthcare going forward. So in this area, we have also been able to put together presentations and a webinar series for individuals who would like to work in this space. It's a global webinar series. It's been a series that is available to you once a month, and you are able to look at historical programs. But coming forward in 2 weeks, on October 20th, we'll be having a presentation on how family caregiving is changing in the era of telehealth. In November, we will be doing on November 17th a program on telerehabilitation. So we look forward to you joining us, and you can see where you can get the information here on the screen. But again, our historical webinars are available for review as well. Quickly, as we move now to our presentation for today, I'd like to share that we would encourage and look forward to questions and answers, which we will do at the end. Prior to that, let me just mention that we have information on our Athena Awards for our Women in Technology initiative, and want to remind people that we are accepting nominations through November 6th. And again, you can look for information right there. Again, one more of our outstanding programs that CITRIS brings to our not only campus community, but the entire technology ecosystem. So for today, as we move forward on this presentation, again, we look forward to having question and answers. That will be at the end of the Dr. Jethwani's presentation. You can use the Q&A function at the bottom of your Zoom window and indicate a question by putting, if you type those in, but also a thumbs up. We'll advance it very quickly, and we will not be using the chat function today. But we will try to get to as many questions as possible once Dr. Jethwani completes his presentation. And with that, I'd like to introduce Kamal Jethwani, a great friend of CITRIS, who is the founder of Decimal.health, and he will be discussing, as you know, the explosion of digital health, and is this really sustainable or hype? And we couldn't have a more outstanding presenter in this area, because Kamal has been a leader in this space, not only in the US, but internationally. He has over 15 years of experience working in the space, digital health, product strategy, design, validation of programs, and he's looked at literally hundreds of different startup companies. Previously, prior to founding Decimal.health, he was the head of product development at Partners Healthcare as Senior Director for Connected Health Innovation, and Kamal led a team of over 50 designers, developers, clinicians, technologists in the developing digital health solutions, testing them, and helping them scale and get into the community, including FDA approval. He is extraordinarily well published, He is cited over 1,000 times and has also been an amazing presenter. We're very fortunate to have him. He's presented over 500 different keynotes in industry. And final point, Kamal's background, where he received a master's in public health at Harvard and his MD degree in Mumbai, India. He has most recently been coming, before we have been privileged to have him come here to California, was a faculty member at Harvard Medical School and Mass General. And it is now our pleasure to have him working with us. And in fact, Decimal.health will be working with CITRIS on 2 of our new telehealth programs, Lighthouse and Activate, which we will be sharing in the future with you. So it is my great honor to turn the program over to Dr. Kamal Jethwani.
Thank you so much, David, for the kind intro. You're always very kind, and you always do it much better than I do it for myself. So thank you. I appreciate that. So as David said, I've worked with David and CITRIS for several years now, and it's really exciting to be back in the fold here and be here in the neighborhood. We recently moved over to the West Coast and live here now in the Fairfield, Napa area. So outside of the fires, it's a really, really fun place to be. So thank you again for having me. I'm really excited to talk about sort of the COVID era and what that has done for healthcare delivery. Being a primary care physician myself, when I started my career, I was really focused on how do you create more efficiencies and how do you make the care delivery process more interesting and engaging for our patients. We have been thinking about and trying to make telehealth and digital health possible for decades now. And before COVID, there was always this high willingness to adopt telehealth. We see sometimes, if you break it down by age, over 70% willingness to try telehealth. But overall, in the United States, only 8% of the country had ever used telehealth. And if you see, it breaks down again by age, where the adoption was double of that below the age of 34, but rapidly declined above that age group. And so with just an 8% adoption of telehealth prior to COVID, and given the high level of sort of willingness to adopt, there was clearly that gap, and there was clearly that chasm that we hadn't, as an industry, figured out how to fill out. And the other thing is, over the last decade, also the industry had been pretty busy at work, coming up with different ways in which they could engage people. The digital health industry has been growing steadily over the past decade, despite the what we would call slow uptick by consumers. Tons and tons of activity monitors and biosensors that look at physiologic data from patients have been available. They've been getting better, and they've been getting really enticing in both design and form factor, but also in the kind of data that we're producing. And today we can really do Star Trek level monitoring of people. But again, adoption of these devices has been pretty low. 318,000 health-related mobile apps are now available. And as you can imagine, the utility of these, or the use of these prior to COVID, has been pretty low. And in addition to those mobile apps, there's 340 consumer wearable devices that have been approved by the FDA or cleared by the FDA for use in a healthcare setting. And with this huge amount of sensors available and a huge amount of investment that has gone into all of these, adoption of these was pretty low still prior to COVID. On the other side, one of the reasons we personally think that adoption has been low has been the other side of the equation, which is not consumer demand, but actually provider demand and provider adoption. So if you look at this, across all of the different determinants of what makes a provider likely to adopt a digital health tool, the perceived patient usability, accuracy of the device, privacy, security issues, malpractice risk, financial incentives, et cetera. As a result of all of this, we saw that the adoption to date before COVID had been very low, only about 26% for wellness and prevention, which are a low risk modality, and only about 13% for any condition management. And by that, we mean any chronic condition management or any real illness or healthcare use. And those low levels of adoption sort of trickle down into why utility of these tools has been so low thus far. But we, in the industry, we almost think about COVID as the big bang for digital health. We feel like this has been really the birth point of what's happened to digital health. And there's a reason for that. The first thing is right away, as soon as COVID happened, there was the necessity to immediately allow for our providers to be able to use novel methodologies to be able to see our patients. Right away, as soon as we saw the pandemic announced, the Department of Health and Human Services released a notification that allowed discretion for telehealth remote communications during COVID, which allowed providers to really figure out on their own and with their own discretion what they want to use, what kind of tools they want to use for remote communication with their patients. Skype, Teams, Zoom, all of these became fair game as different practices started to scramble on what they needed to do to be able to keep business running as usual. We even saw a drastic increase in the use within health systems about what they kind of used for telemedicine. Novant Health saw a increase from 200 to 12,000 visits, video visits per week. In NYU, we saw only about 20 virtual care physicians prior to the pandemic, and it going up to 1,300. And not very far from us in UC San Diego, currently more than 50% of their visits are happening via telehealth, primary care. So huge uptake in very, very short amount of time, something that we couldn't achieve for decades sort of happened within a couple of weeks after COVID. In addition to all of these things happening, the other reason why these things had to happen was that hospitals were losing money. 35% of our acute hospitalizations went down. Our acute hospitalizations reduced. And this is where some of the hospitals do generate revenue. And with that kind of losses that they were accruing, telehealth became really important because we didn't want to lose volumes or ways in which we could care for our patients, because those acute hospitalizations were still required, they were just not happening. And that all of this together has resulted now in even large health systems, which are traditionally known to be very slow moving, to move from pilots to full scale implementation within a matter of weeks after COVID. And that is a huge number because usually it takes a couple of years for any system to move from pilot to full scale implementation, even after having 100% buy-in from all different levels of the organization. So to be able to get that level of buy-in and move that quickly to implementation is a huge deal. So what this tells you is that the opening up of the regulation and policies really opened up the aperture, and we got a lot of really interesting sort of uptake from providers for telehealth. And investors were watching, and again, being in California, I'm sure everyone is very attuned to this, but telemedicine saw a 3x increase in funding in 2020 compared to the same duration in 2019. And all of this, again, as a result of COVID-19. So as you see in the graph, from 2019 to 2020, we saw almost investments going from about 600 million to about 1.6 billion. And Q2 and Q3 recording some of the biggest increases, which again is interesting because that is when some of the major announcements on the US COVID timeline were made by the administration and by what was happening in the country. Despite all of that, the investments have just been going up because I think investors are watching that this is one industry that's going to benefit from what may have been a really difficult situation if these technologies didn't exist and if we hadn't been working over the last decade on making some of these things happen for hospitals. In addition to sort of just the total number of dollars being invested, we also dug in a little bit into what kind of value propositions were being funded. And on-demand healthcare services. So these are companies that deliver either immediate or near real-time healthcare services was the biggest winner as a category. We saw 48 total new deals and about $2 billion invested in just that value proposition. And then the second and the third were R&D. So the companies that are catalyzing R&D and enabling the administration and execution of new R&D, so drug discovery, clinical trials management. A lot of these companies focus on allowing for these things to happen remotely, which again, if any one of you is familiar with the drug discovery process and the clinical trials that go behind it, it's a very manually intensive process. And so companies that are helping investigators do this remotely sort of started to get a lot of attention. And that was the second most invested sort of category. And then obviously fitness and wellness, with gyms closing down and restaurants closing down and people not really knowing what to do in terms of keeping fit, and also taking care of their health, given the fact that going to a hospital wasn't that easy. That's another category that received a lot of attention and a lot of investment. And again, about 21 deals with over $1.2 billion invested in this time frame, just between Q1 and Q3 of 2020. So a lot of attention, but very clearly the winners here were on-demand healthcare services, and on the consumer side, fitness and wellness enterprises. But given all the changes in regulation, all the changes that providers did, and all the changes in the investments, what is really happening with our patients? What are people doing for their healthcare? So here's the profile of a peri-pandemic healthcare consumer. They're hesitant to enter healthcare facilities. They may have changing insurance coverage, with about 30 million people losing their jobs, and along with that, their benefits. They're more open to data sharing because they're now starting to get used to the fact that they will be only seeking help remotely for the most part. A huge willingness to use telehealth, again, because of number one, which is their hesitancy to enter healthcare facilities. On the other side that we started seeing was a bigger exposure of the fact that mental health is a huge area that there is an unmet need in. Our mental health capacity was completely tapped out in the last few months since March, where more and more people were seeking remote mental health and not having as much access as they wanted. People are increasingly getting socially isolated because of obviously stay-at-home orders and quarantine requirements. And a lot of people are putting off their care, and mostly the care that gets put off is care that is not urgent, which ends up being preventative care. So a lot of people sort of, have stopped getting their routine preventative care, which may result in us as a society having an uptick in chronic disease in the next few years. And then finally, just newer social determinants of health that have emerged, with people losing their jobs and benefits, and as a result, their food, housing, and other things coming into question, with being socially isolated and their social structures and caregiver structures being broken, now are dealing with things like loneliness that they probably didn't have to deal with before, given what they had already created around them. So this is your new peri-pandemic healthcare consumer. This consumer is really prioritizing very different things compared to the pre-pandemic consumer, and has a very different approach and attitude towards digital health. And the real question is, what happens? Number one, what happens when everything goes back to normal? Will this consumer go back to the way they were before, or are some of these things harder to change? And are some of these newly acquired openness to things also some things that are harder to change? So for example, once they've used telehealth and they like it, will they really go back to not using it? We don't know this, and again, that is something that's quite an open question. And the second thing is, what is the new normal going to look like? How long are we going to stay in somewhat of a modified reality as it relates to stay-at-home orders, working from home, our economy, as well as our social isolation? And so those are all open questions. But is it important to see what the pandemic has done to some specific characteristics within our consumer population? So the first thing I'll cover is the delay in seeking care. So about 56% respondents to a recent survey said that they have delayed their healthcare visits due to the pandemic. More than half of them are obviously because they're just following their state's orders, but there are a lot of people who are also scared to enter a medical facility, and there are a lot of people who are who are saying that their care, the care that they need, is not being currently offered by their healthcare facility. And so if you think about like minor procedures, outpatient procedures, dermatology, there's a lot of different services that may or may not be being offered either. And there are a small minority that do say that, they can no longer afford the care, potentially due to loss of insurance. And that is, again, something that is going to be, that is already a talking point as we're thinking about the elections, but is going to become more and more of an important thing as we think about how we reorient care going forward. The second thing I wanted to talk about is what happens to all the delayed care. So all of this delayed care is not just something that we don't need. Maybe a very, very small portion of it is something that we may not need, but all of this other untapped care is going to have to be taken care of at some point. So 67% people said that they're extremely likely or somewhat likely to visit a healthcare provider for the care that they've delayed at some point. But what's really interesting is that it's not likely that it's going to be immediate. What we're hearing mostly is that over 80% people are probably going to do that after a longer gap than what we think is going to happen. So it's not like they're going to go in within the first month of everything going back to normal, that there's going to be a lag in that. And that's an interesting finding, because I think our comfort and openness to going back to normal is going to lag what we do from a regulatory standpoint or a policy standpoint in terms of opening up our hospitals and our economy, et cetera. And then the other question was, when they do go back, what are people going to seek first? And obviously, primary care and routine dental seem to be the two things that ranked fairly high. So the question now, this is a little bit tricky, because now you ask people, what do you think is likely to stay after? And it's a tricky question because people don't really always know what their life will look like afterwards. So this is a little bit of a projection, but the answers that came back were still pretty interesting. Over half the people said that they're more likely to use their plans telehealth or virtual care services after COVID-19 as well. Just under half said that they would definitely want to use their online appointment scheduling system through their health plan. And about 44% said that they would use their online chat feature that they have been offered during COVID-19. They would want to use that afterwards as well, which again signifies a pretty big shift in consumer sort of feelings and attitudes towards digital health and some of these sort of very tactical things that now we're getting used to more and more due to COVID. So that's all about our consumers and what our consumers are thinking about. And so what is here to stay in reality? And more than thinking about or projecting what is here to stay, I think I want to frame it in the sense of, what do we think is leading to some of these things being here to stay? What are the determinants of what might happen, right? And the three key areas that we're thinking will make a huge difference in determining what is going to stay and what is not going to stay. Obviously, number one is policy. We need to make sure that the policy changes that have been made thus far either continue or get better. The fact that consumers want this should have some role to play in that. Linking to that is consumer demand. And so, as consumer demand stays or stabilizes or increases for digital health, we hope that that is going to be an impetus for companies to be sort of doing more and hospitals to be doing more in this area. And then obviously matching that would be the investments. Can we enable some of these technologies to actually, sort of be successful through the right kind of strategic investments that we can make in some of these areas? And we feel that the confluence of all of these three different areas is what is really going to determine where we go from here. And these are the things that'll help our changes in digital health stay a little bit more stable as we think about it. So let's dig into that a little bit one by one. So the first one, obviously, is consumer sentiment around telehealth. We've already seen that consumer sentiment has increased. This is another study actually done by McKinsey, which said that prior to COVID, 11% people had used telehealth across all of these different demographics and age groups. And right now, in terms of an interest, 76% people want to use telehealth going forward. And it's a huge jump, even if we discount some of that 76, saying, people don't really know what they're going to do after COVID. But even just based on that, this is a huge shift. And what's really, really interesting is that if you dig a little bit deeper, these kind of changes seem to be cross-cutting. So here's a split of personas that we think about as we are thinking about who the healthcare consumer of the future is going to be. This divides up the healthcare consumer based on their health status. So on the top, you're going to see healthy people, people with one single chronic disease, and people with multiple chronic diseases. And down on the left, you're going to see age groups. So again, dividing it up between people under 30, then 30 to 50, 50 to 64, and then 65 plus. And so it really divides this into 4 groups. And within each of the groups, if you look specifically at their openness and interest in telehealth, it's really interesting. So if we start with the healthy mavericks, people who are either healthy or have only one chronic condition and are sort of below 50, they're 3 times more likely to engage with telehealth compared to other segments. And about half of them want to use telehealth for better access to affordable mental health. And that is a huge jump in demand that we have been able to record. We always knew mental health is something that people want, but about 50% people looking at telehealth specifically for mental health is a huge change. The second group is sort of quality seekers. These are people who are a little bit older, but still working, still between 50, below 65, and still in that same bucket of like being healthy or having just one single chronic condition. Even for them, there is an increased willingness to try out digital solutions. And the goal here for them is to save time. So a lot of this is oriented towards convenience for this particular group, which is really interesting. The third one, which we call frequent flyers, which are people who have multiple chronic illnesses and can be anywhere from the age of 18 to 65. They could be digital natives if they're younger, and if they're older, they're not. But even then, there's a huge increase in willingness to use telehealth for urgent care. And so this is sort of their sort of use, because they use healthcare facilities so much that being able to use telehealth for urgent care hits upon convenience, but also hits upon access, because right now urgent care and emergency care are just harder to access mid-pandemic, and potentially will continue through after the pandemic as well. And then finally, you would think that, sort of people above 65 who, again, across the entire healthcare spectrum may or may not be that open. But what we found is that, again, very interested in engaging with digital health solutions, particularly for things that like access to prescriptions and follow-ups. And again, those are the pain points that they're looking at solving. So again, across the spectrum, even if you dig really deeper, there are slightly different nuances and slightly different areas of focus, but still, the likelihood to engage with telehealth and the interest in engaging with telehealth is up across the board. And we think that trend is here to stay. On the provider side, that's number 2, our health systems and independent practices and all these people have been reporting a 50 to 175 time increase in number of telehealth visits, which is huge. Providers who had been probably doing no telehealth are now doing all telehealth. And there's probably a spectrum between that depending on your specialty area, but that's a huge increase. But more than that, what's really interesting is that 57% of providers are now viewing telehealth favorably than they did before COVID. And that, again, more than half of the people are now thinking telehealth is actually a good thing. And almost 2/3 are more comfortable using it. So again, compared to people who were using it before, that may or may not have been that comfortable, now they are. So part of it is a forcing function because we kind of now have no choice. But I think given that forcing function and giving them enough time to practice with it has resulted in people getting way more comfortable with it. And so now if you view it more favorably and you're more comfortable using it, again, it feels like that is something that seems to be here to stay. I apologize. Okay. So the other thing on the provider side, I apologize, the slide is a little bit blurry, is that providers are also already prioritizing digital tools. So not only are they more open to it now, but there's also areas within the care journey that providers are focusing on for digital health. The first one is improving the customer experience. 81% providers actually think it's a high priority, but only 11% have the capabilities to be able to deliver on that right now. utilizing digital tools to engage customers. Again, high priority, over 40% people saying they want to do it, and only 4% saying they have the right capabilities for it. And then offering a variety of virtual access points. Again, over a quarter saying it's a high priority, only 3% people saying high capability. What this tells us is that there's a high level of willingness to try this and increase access within their practices, but there may not be as much skill or capability to do it. And this is a white space area for all of this digital innovation, all these startup companies that are coming out to be able to address these specific gaps, because look, the demand is there, they don't have the capabilities. And I really think that if we can bridge this gap and match this up before the end of the pandemic, that most of these practices would have adopted these. And then once you have the adoption there, it should be there to stay. And then the third factor always is regulation. Interestingly, due to COVID, 80 new services have been temporarily approved by CMS. And they have lifted several restrictions that usually traditionally in the past made it harder to do telehealth. And all of these different things have made it really easy and really attractive for providers to try telehealth, because they're now getting paid for it more, and their CMS is looking at this more favorably. But specifically, there are two things that are driving this trend, and hopefully will continue to drive this trend down. The first one is value-based care. So in addition to all of the value-based work that had been done before, which very simply just means that as a provider, I get paid on the quality of care that I provide to my patient and their outcomes, rather than the number of times they come to see me. So back in the day, I'd get $110 when you came to see me, no matter what I did with you, obviously within certain, parameters. Now I get a fixed amount for you, whether you come to see me or not. But I only get that if I keep you healthy and I keep you out of the hospital. So that's just a shift into value-based care. But in addition to value-based care, which is something that has been going on from Obamacare's era, now we just recently saw 5 new primary care models being pushed by CMS as a response to some of these newer changes that have happened. And specifically what they're doing is they're making it easier now for smaller primary care practices to be able to enter some of these arrangements. So they offer a flat revenue stream for each patient, and they offer up to 50% bonus when a patient remains healthy and out of the hospital for smaller practices. And then the practices are expected to put the investment in for making some of these things happen. And up to 10% of the revenue could be something that the practices could be expected to spend on providing some of these additional services and offerings to make sure that they're taking care of their patients. For larger primary care practices, it's the same thing. You get a bonus, but they also take a downside risk, which means that if your patient does get sick, then the cost associated with taking care of their additional sickness is something that the practice would have to bear. But overall, what we've seen in the last decade or so of experimenting with value-based care is that this ends up being a highly motivational and revenue positive exercise for practices to engage in. So the fact that CMS is still pushing some of these new models, even as recently as this year, tells us that this is something that that's a future that CMS wants to see happen. More interestingly, CMS recently relaxed the rules around remote patient monitoring. One of the key things, again, to think about this is telehealth is simply a video visit, which is, I get on Zoom and see a patient, and we interact over Zoom, and then I give them a prescription, they go to CVS to pick it up. The second modality of telehealth, which has been gaining a lot of steam recently, is remote monitoring. So you might get a Fitbit, or you might get a blood pressure cuff or a pulse oximeter, and you take it home, and then you collect data on it on your own. You measure your blood pressure, for example. That data gets transmitted to me as a provider. I look at it, and then I can react to it. I can change your medication. I can tell you to eat healthier, or I can say, this looks pretty bad. I want you to come back in and see me, or I want you to go to the emergency room, right? All of those are possibilities. Remote monitoring has been something that has been around for a while, but has not seen any meaningful adoption up until recently, when CMS said, hey, doctor, I will actually pay you. I will reimburse you for the time you spend looking at the data on a dashboard, and not just when a patient comes to see you in person. And this has really created an incentive for practices to try it out. And so very simply put, as a doctor, I can get up to $21 per patient per device when I set up the devices for them. then I can get up to $69 a month for just giving them the remote monitoring device and getting that data into my EMR. And then I can get about $54 per patient per month for actually looking at the data and monitoring it and giving them some treatment based on that data. Combined across a large practice, there's hundreds of thousands of dollars to be made by provider groups if we can just make remote monitoring something that's useful for patients and provide good clinical care as a result of the data. What this has done, as we're going back to thinking about, are these things here to stay or not? What this has done is it has opened up providers to being able to try some of these things. Providers that were initially skeptical about, home blood pressure, will they even do it correctly or not? What if they're standing instead of sitting, et cetera, et cetera. These policies allowed providers to say, oh, I'll give it a shot. Let's see what this feels like. And as a result, what has happened is that we have now de-risked this for providers. So not only have patients gotten a chance to work with this and thought this is really interesting, but providers have gotten a chance to give these programs out and look at how that has impacted their practices. What we're seeing is 90% patients have now reported that they want some sort of a digital connection with their doctor, even if their doctor is willing to see them in person. 69% healthcare professionals have now ranked remote patient monitoring as the #1 reducer of overall costs. 62% patients said that that remote monitoring devices that send data back to their providers are actually helpful, right? And over $9,000 of RPM of ROI has been reported for RPM per patient in the literature. And so if you think about all of these different things, what CMS has allowed us to do because of these reimbursement codes is give this a shot. And what we have seen is that practices are reporting this is helpful. Patients are reporting this is helpful. Practices are reporting that this is now actually a value add and that it's positive for them. And as a result of all of these different things, we think that the positive experience people are having with technology, as a result of that, I feel personally that it's here to stay, that this is something that will stay and will stick around even after COVID, because we're now getting a chance to experiment with these things and see the value on it. So at the end of this, again, sort of my bias is that there is tons and tons and tons and tons of innovation happening in here. There's a lot of money being invested in here. There's a lot of providers, a lot of very intelligent people trying to work on this and make this a reality for us. And if we can keep our policy, our demand, and our investment portfolios appropriately targeted and continue with the positive changes that have come about because of COVID, that we think that this perfect storm is going to set us up perfectly to revolutionize how we deliver healthcare, and healthcare delivery probably will not stay the same ever again. So I'll stop there, and David, over to you for Q&A.
Wonderful, Kamal, and thank you very much. And we are already getting some questions in from our audience, but thank you for taking us through an amazing overview of what's occurred over these last 6 months, but how it really sets us up for digital health expansion in the coming years. I think you've made an extremely strong case. And yet we have a few questions from colleagues, and we encourage you to use the Q&A function, and we'll try to get it to as many as possible. But please, any items that you'd like brought forward for Dr. Jethwani, we will take those. One of the things I'd like to get us started as we're looking at some of those questions, Kamal, is that the CITRIS innovation ecosystem and our colleagues at UC Davis Health and at our Foundry, we have a very large number of individuals who are involved in digital health startups, who are engaged in from both the provider and the ultimate consumer side of this, as well as investment. Could you share with us some of your thoughts, since you've overseen so many startups and worked with so many companies working in this space, what you think the key issues are for our innovators, our technologists, our engineers, our data scientists who are exploring this space? What are the key things they should be looking at as they develop their own technology solution, as they look at clinical opportunity that could benefit from digital health, what would you suggest to them at things they should be focusing on at this point?
Yeah, that's a great question, David. So the one thing that one of our guiding principles has always been when you are an entrepreneur, engineer, or founder of a technology company or an idea, one of the key things to think about as you're developing this is that it needs to be rooted really clearly and strongly in consumer demand. We find a lot of times that technologies get built up just based on either physician feedback or patient feedback or none, or just one person's personal experience. And a lot of times those companies or those ideas find it really hard to find grounding, and they try to go and make a sale, and it doesn't quite happen. So really thinking about the specifics and the details of like what the demand is and why the demand is there and how can you truly address that demand, I think is important point number one. Number two, really thinking about the last mile as importantly as you think of the rest of the technology. So a lot of times we spend a lot of time coming up with the best AI algorithm or the best piece of hardware that is very fancy and that's really works really well. And what we forget about is the last mile to the provider. How will the data get into that? Is it real time or not? How do you integrate with the EMR? How will they respond to the data? What happens if they can't? Like just the last piece of the puzzle that ends up becoming the downfall of a company that has spent millions of dollars on creating really good technology. So designing from the get-go with that last mile in mind for both the patient and the provider, I think is really important. And the third one is, given everything that's going on in the industry right now, it's almost inexcusable if you come in without a real business model. Back in the day, when I was at Partners, we would get a lot of companies that would say, this is going to help you reduce cost. And we'd be like, yeah, maybe it'll help us reduce costs, but like that's not a budget line somewhere, right? And I don't even know like where it's going to reduce cost or will it benefit the payer or the provider? But we would give it a shot because we had no other way to think about it. In today's world, with the number of reimbursement opportunities and real value or real revenue opportunities available, it's almost lazy if companies don't actually come in and offer a solid business plan that is easy for providers to adopt with. So I think that that's also almost a prerequisite. You should always have a really clear revenue model, business plan, and go-to-market strategy for the providers.
That's wonderful. And I couldn't agree with you more, particularly on the last point. I think if there's one thing we've seen within our CITRIS innovation ecosystem and across our 4 campuses, and now at our Digital Health Resource Center at UC Davis Health, it is people having to really understand the business side of this. We have amazing engineers, data scientists, clinicians, but it's that understanding how it fits within the current healthcare system and where this system is going, as you so nicely laid out today. So thank you again for reinforcing those points. We have several other questions. I think a key one that is very important are the barriers to these issues, because there still are going to be barriers from either the provider side or from those individuals who are creating the new digital health solutions, much less even obviously from the consumer side in terms of patient engagement, digital literacy, et cetera. What would you call out are the barriers that are still, that our listeners today should be focusing on, that they should be aware of and anticipate as they would move into this space with their own programs or working with health systems?
Yeah, I always think about barriers in 3 categories, and I think most of those categories are even relevant after COVID. Number one, technical barriers, your integration into the EMR. How is the provider getting the data? How are they responding to the data? Is it a medical legal part of the medical record or not? Are they having to log into a separate portal? That's going to be a whole different workflow. What happens if they take action on something but it doesn't get recorded to the medical record? Just thinking about the workflow dynamics and the technical part of the workflow dynamics is really important. And I feel like a lot of providers just like think about that and get really anxious and get heartburn and then don't want to adopt. So that is one thing that's really important to think about. The second barrier is reimbursement and sort of monetization. It's very hard to run a business on the promise of savings in some future, right? And so when companies come in and say, we can help you save money 3 years from now, it doesn't put food on the table today. So really, again, reimbursement is a second barrier. And the third one is a lot of times companies forget that we are healthcare providers, we're healthcare organizations. We are not software engineers. We're not technology companies. So, do not expect my staff to have to worry about troubleshooting technically, about addressing calls where they say, I dropped the blood pressure cuff in the toilet. What do I do? Don't know, right? You need to take care of that. And so the number three I'll say is that interface or the customer support as it relates to our patients. If the clinics have to take that on, that's a huge burden, and they don't want to do that. So that is something, again, that companies, the account management piece and the technical support piece for both the providers and the patients is something that I think companies should really think about, because that could become a real barrier.
Thank you very much. We have a few questions related to data, both information in terms of so much of what you presented today, so nicely synthesized. We're both interested in sources of where that comes from, and are there standard approaches that we can all be looking at in the future? But then on the data itself, have you been seeing findings yet, particularly as we're seeing these incredible changes in terms of actual data to report on quality of care in terms of outcomes, in addition to some of the advances in the amount of care and some of the reimbursement changes? So both points, are there standard places we can all track some of this going forward in terms of where you pull this great information from? And then again, as we look at, because evidence-based is what's really critical moving forward, how do you envision that we're able to get that? Will that be from up to individual companies or from health systems, or do you see us getting at it from federal data sources?
Yeah, so that's an interesting question. I think that from an evidence standpoint, I'll start there. There is evidence already about telehealth, remote patient monitoring, digital health tools, health and wellness tools, around them having an efficacy on the outcomes that we're measuring. So that data always existed, and that was always there. I haven't specifically seen data come out post-COVID on these, but also, if anyone has published a paper in a journal, that that's probably going to happen in 3 years. There's probably more podcasts and blogs and white papers that are available than actual research papers. But from an evidence standpoint, we as an industry always knew that there is efficacy behind remote monitoring, telehealth, and digital health. Now, how do we go ahead and track some of these? So there are a lot of organizations doing reports. I pulled a lot of this from CMS's website, but also McKinsey and Deloitte and others have been doing some really good consumer reports. So for now, those are the ways that we're tracking activity in this field. A couple of things that I've been keeping my eye on is utilization of codes, because that really tells you how much uptake has been there overall in the country. And so one example I'll give you is just within 1 month of March, we saw the RPM reimbursement code utilization go up by 200% just in the 3 weeks. And so that was, if that's any signal. And again, CMS data lags real time a little bit. So we probably only have data till June, I guess, right now. But even just within a month, we saw 200% increase in RPM codes, not telehealth. And so that's telling us that, there's already an immediate uptake that happened. And I'm pretty positive about that trend staying. But that's, again, something that, CMS publishes pretty openly. The other thing to start to think a little bit about is value-based care deals. A lot of big hospitals stopped taking on value-based care initiatives because the ROI wasn't quite there, or it's really complicated to enter into those contracts. And we saw sort of the number of value-based contracts going down. And then again, after COVID, we're seeing some of that sort of rise back up. And a little bit of that has to do with CMS opening up new opportunities, but also organizations now thinking that is going to be something that is important for them to sustain in the future. So that's another trend to watch out for. If you see that going back up again, that means that, we figured out a way to manage populations a little bit better through digital, and that probably is going to be helpful.
Fantastic. Thank you. We have a few questions. You've spoken to telehealth, remote monitoring a number of times now. We know this is a major change. We know that at CITRIS, as we are engaging on several major innovations, the Lighthouse Project, Activate. We encourage all of you to look at our website for more information on those. And again, the webinar series we mentioned at the beginning to talk about trends. These are global trends as well. But we have a few questions related to some of the challenges even in that area. Do you envision major pushback? I mean, the key issue for us is both the regulatory and policy side of telehealth sustainability. You've mentioned all these amazing changes that have occurred in the 6 months, but we all have started to see some changes where even though some of the new CPT codes, new changes in telehealth are supposed to be permanent, we've seen pushback starting. We've seen it both the regulatory and the policy level and from major providers. What do you see as the direction of that, and what will it take to maintain telehealth and remote monitoring at the levels we currently have going forward?
Yeah. So currently, because of COVID and because of the lack of time we had, the regulators and payers have allowed for the same level of reimbursement for a virtual visit compared to a face-to-face visit. That was unprecedented because we are expected to spend less money on a virtual visit, right? But we're getting reimbursed the same amount. What that has done is it made it almost a non-issue for providers because it became an equivalent visit for us, and a lot of providers sort of adopted for that reason. Obviously, besides the fact that we had no other choice. I do feel like that will be readjusted once the restrictions are lifted. But the reality is that even with a slight reduction, the balance sheet works out because you do spend less money, you do have less overhead. If you're seeing the patient not in a facility that you need to keep the lights on and the air conditioning on and the heat and all of that stuff, that over time that math works out. So I do expect some changes on that, but not anything that'll be so drastically different that might discourage providers from actually engaging in that. So that's number one. Number two is to not think about telehealth in isolation, but to start thinking about telehealth in addition to some of these other programs like remote patient monitoring, like digital health. And those are all net new reimbursement opportunities. In the past, if you asked us, would you do, when someone would ask me, would you do a telehealth visit? And my answer was like, we've been doing telehealth visits for, 200 years, right? Because, ever since we got the telephone, we've been doing telehealth visits without getting paid for it. So the correction that happens where now I can charge for every telehealth visit that happens, which really a lot of practices have been doing at least 20 to 30% of their time on telephone visits that don't get reimbursed. Those corrections will end up actually making telehealth visits, even with a slightly lower reimbursement, as attractive, if not more. But then if you think about it as a package of everything, where you do telehealth and you do remote patient monitoring, overall, that package definitely continues to be pretty attractive. And so I don't see much changing in that.
Thank you again. One of the issues, what you've presented is a focus, and you have a fantastic history working in large health systems, really even with value-based care, with people who are insured and already in the healthcare system. A number of our listeners today are asking, how do you see this translating? And again, we're doing this at CITRIS through Activate and Lighthouse, working with at-risk populations, underserved, not only different population groups, such as particularly rural communities, older adults, as we know, are desperately needing this type of service at this point. But we're looking at the issue of individuals that are not even in the healthcare system. So how do you see our entire society benefiting from these wonderful advances in digital health?
That's a great point. And, one of our biggest concerns had been sort of with digital health, just like anything else, would end up worsening disparities. And, like it would end up becoming the tool of choice for the younger, more sort of technically savvy people, and that, people on the margins would be left behind. But I really think that if done correctly, this could be the great equalizer, right? Where people may not have to live in an urban area to get the best quality care, where they can just zoom in and be able to speak to someone at UC Berkeley, UC Davis, even if they live a couple hundred miles away. And so that's an opportunity. I think the other opportunity for hospital systems is to start to spread their net much wider. When I was at Partners, we had an office that would think about, okay, how far are we going? Is our sort of sphere of influence 50 miles or 60 miles from our hospitals? And if you want to go beyond that, then we have to go acquire a primary care clinic there. Well, not really anymore, right? Now the entire country is your oyster. How do you compete now that it's fair playing grounds for people who may not be part of the healthcare system that want to become part of it? Someone living in a rural area in California could still dial into MGH. And so you're going to have to compete for that. So as a health system, again, really coming up with the right approach for that and using digital as a way to make that happen, I think is an exciting opportunity. And I think is a real opportunity to expand the amount of access to people who may not have access right now. The second thing is also right sizing the access. Probably primary care is something that's available to people, but as you saw in my presentation, mental health is a huge need. And that's an even bigger issue, even in many urban areas where there's a 2 to 3 month wait time to be able to go and see a psychologist or a psychiatrist. Now, if we completely open up the entire country where you can go and see a psychiatrist in Pennsylvania, if you live in California, now again, right sizing the right kind of access is going to be another opportunity where we can do it. So what that leaves out is people who don't have the technology and people who don't have the affordability for the technology. And that is something as a society that I think we need to address. There's a lot of companies working on, and as you said, David, on our projects, we're really thinking about how do you figure out the solution to someone who does not have internet and lives in an area that does not have any cellular connection. What do you do with that? And again, through grants and through government effort, we may have to think about how do we bring those people up online so that they can benefit from what I see is going to be a positive change for everyone.
I think that leaves many opportunities and challenges for our innovative colleagues that are on the call today, and really a challenge for everyone. In the remaining 2 minutes, one quick area, because we have a wonderful group of health informatics folks, data scientists, computer scientists, engineers that are working on how we use big data and data analytics and predictive analytics. Very briefly, could you share how you envision those areas integrating within this space? We know that there's huge opportunities from major companies and large data sets, but what would you say, what are going to be the big opportunities in digital health on the point of care area?
Yeah, that's a great question. And you see me nodding very aggressively because that's a super exciting area. And I think it's a huge opportunity. So currently in our healthcare systems, we have our data from the EMRs, and we have that data. And, I would say that we're just about over the last 2 years, after 2 decades of having that data, starting to make some sense out of it and starting to figure out how to use it for anything more than an individual interaction. Now, we have the opportunity to get that data, obviously, and we have that. But now we have the opportunity to add to that data that's coming from people on a real-time basis. When before have we ever had 24/7 data, monitoring data from people, right? Where they wear an activity tracker, or if they have a continuous glucose monitor, where we get 24/7 data from people that can now come in and augment our data sets to give us a bigger, fuller picture about what's happening to this person in conjunction to our data in the EMR already, in conjunction with some of the data that's even coming out of their smartphones. Combining all of these different data sets, getting to understand the context behind the data, the actual data about what's happening to them, and any of the medical information that we have about the medical record together, I think can give us really interesting insights into not just what's happening with them today, but what could happen to them in the future, and then how could we actually make it happen or stop it from happening. And I think that's the exciting area. I think one vision of the future may not be the vision for everyone, but one vision of the future is that doctors are not necessarily people who see patients or 8 to 10 patients a day, right? Doctors are sitting and figuring out how to create the right algorithms for this data, and then are treating dashboards of people, right? Where they're sort of they're playing the role of figuring out how to optimize everyone's health. because they're getting all this intelligence fed into them through these intelligent algorithms, and that these devices that are on us are the ones that are actually delivering the care that we need and keeping us at optimal health. Maybe with all of this, in 3 or 4 decades, we won't even think about chronic diseases because they won't exist anymore.
Well, that's a wonderful way to end our session today, Kamal, and it's a great challenge to all of us. We can't thank you enough. We have, unfortunately, due to time, have a number of questions we're not able to get to. Please, we will share those with Dr. Jethwani. We will leave it to him in terms of being able to share slides, but as you know, we have all of our research exchanges recorded. You can see those in the next few days, this presentation included, on YouTube. And we will be providing that information, and you can actually connect with Dr. Jethwani through his LinkedIn connection that was provided to you earlier. So without further ado, I'd like to thank Kamal for an outstanding presentation. You've really challenged us in our thinking and really a wonderful job of bringing us up to date where we are with digital health. And we wish all of you well. And please join us next Wednesday with our next research exchange here at CITRIS. Thank you all.
Thank you, David. Thank you for having me.